My pleasure to turn the conference over to Elisa Arispagachaga. Please go ahead.
Thanks so much, Ryan, and good afternoon to everyone on the line. Thank you for joining us. I'm very excited to welcome you to today's webinar from the AHA Physician Alliance in partnership with the American Lung Association. Today's session, Saved by the Scan, Driving Up Utilization of Lung Cancer Screening to Drive Down Lung Cancer Mortality, is a session that I think is of great importance to all of us and one that we all can learn quite a bit from. So I'm really excited to have Dr. Albert Rizzo, who's the Chief Medical Officer of the American Lung Association and Chief of Pulmonary and Critical Care Medicine at ChristianaCare in Delaware, to join us and run through some of this work. So Dr. Rizzo, with that, I will turn it over to you.
Thank you, Elisa. Hello, everyone. I'm pleased to join you today for the webinar during Lung Cancer Awareness Month. Although lung cancer remains the leading cause of death among Americans, there has been a dramatic 13% improvement in lung cancer survival rates over the past 5 years. This is largely due to the exciting advances in targeted immunotherapies. In fact, there's been over 30 new lung cancer treatments approved by the FDA since 2016. We predict this trend will only increase as we begin to see data reflecting the lives saved by lung cancer screening. The American Lung Association is committed to improving outcomes for lung cancer patients through our arms of research, advocacy, and health education. A large component of this is increasing the number of eligible candidates getting low-dose CT lung cancer screening. During today's presentation, we'll cover three main topics. The first will be the American Lung Association's efforts at improving lung cancer screening by our Saved by the Scan awareness campaigns. We'll then review the implementation guide put together by the American Thoracic Society and the American Lung Association. It was published as a PDF in 2017 and then made available on the web in 2018. Then I'll finish up with some highlights of our third annual State of Lung Cancer report that was released earlier this week, which for the first time explored the lung cancer burden among racial and ethnic groups at both the national and state levels. And hopefully we'll have some time for some questions and answers near the end. This has been a particularly challenging year for all of us, but as an organization, it's been so important for us to ensure that we're taking action by continuing to raise awareness of lung cancer as the #1 cancer killer of both men and women, while promoting other lung cancer awareness activities through this month. On this slide, you see some of the important metrics that have been measured to assess impact of our Saved by the Scan awareness campaign. We reached over 500,000 Americans, and it's especially important to see the numbers that indicate action being taken, either by talking to their doctors or by being enrolled in a screening program. I'd like to talk about some of the work the American Lung Association did leading up to the launch and release of our lung cancer screening implementation guide. The Lung Association has been involved with implementation of screening since the results of the NSLT trial were released in June of 2011. As many of you might already know, the trial examined heavy current and former smokers with no history of cancer who smoked the equivalent of 1 pack a day for 30 years and were between the ages of 55 and 74 years old. Today, roughly 8 million current and former smokers in the United States fit this demographic. This study was the first comprehensive clinical trial to actually find that screening high-risk individuals with low-dose CT scans reduced the lung cancer deaths by 20% compared to chest x-rays. So between 2012 and 2015, there were many changes in the lung cancer screening environment. In December of 2013, the United States Preventive Services Task Force gave the use of LDCT, or low-dose screening, a B recommendation, which meant that under the Affordable Care Act, most people meeting the criteria would now have private insurance coverage without co-payments as a barrier. This was followed by a similar decision by the Centers for Medicare and Medicaid, or CMS, in February of 2015 to cover screening for a similar, although not congruent, at-risk population. It was at that time the American Lung Association decided that the next step to ensure that screening is implemented and available to the at-risk population was to work with the American Thoracic Society and develop a diverse group of experts to author the lung cancer screening implementation guide that was then put on the web in 2018. Besides over a 100-page document, we spearheaded the creation of the website, lungcancerscreening.org, a digital version of the guide that allows easier and greater navigation and overall accessibility on how to implement a lung cancer screening program. Before getting to the guide, I would like to take a moment just to highlight our Saved by the Scan campaign. In 2017, the Lung Association launched Saved by the Scan, which was a first-of-its-kind campaign between the American Lung Association's Lung Force Initiative and the Ad Council that aimed to raise awareness of the benefits of lung cancer screening early detection through the lung cancer screening programs. This campaign drove high-risk individuals to talk to their doctors and visit savedbythescan.org to learn more and take a lung cancer screening eligibility quiz. You saw some of the metrics on the earlier slides. 42% of former smokers are now aware of the low-dose CT scan, and 31% are willing to talk to their doctors about getting screened. By telling stories of those who benefited from lung cancer screening on our website as part of our campaign, we are inspiring others to learn more if they can be saved by the scan. I was going to show you a short video, but technology is not going to allow that to happen, so we're going to move on to the next slide. In another effort to increase screening for lung cancer, Winnebago and Neurologica and the American Lung Association joined forces to raise awareness of the importance of lung cancer screening in an innovative new way to bring the potentially life-saving procedure to communities with limited access to this service. Because the American Lung Association mission includes improving the quality of air we breathe, at the 2018 Global Climate Action Summit in San Francisco, Winnebago's new zero-emission vehicle was outfitted with a neurological low-dose CT scanner on board, demonstrating how the unit can be customized to provide lung cancer screening beyond the medical center setting while limiting patients' exposures to vehicle exhaust emissions. The ALA wrapped the vehicle with a Saved by the Scan public service announcement to encourage former and current smokers to take the online quiz to determine their risk for lung cancer and talk with their doctor about getting lung cancer screening done. Although lung cancer screening has been found to reduce mortality from lung cancer by 20%, and so has the potential to save thousands of lives, barriers to implementation nationwide remain. It's estimated that less than 5% of the at-risk population has been screened. With the current eligibility criteria, there are about 8 million candidates, but the uptake in the screening has been woefully slower than we'd like. If the new recommendations by the USPSTF go into effect, with a lower pack year need of only 20 pack years and a younger age of 50 being included, the eligible population will increase significantly, and many more lives could be saved by the early diagnosis of lung cancer with screening. A few of the identified barriers that are listed on this slide prompted the American Lung Association and the American Thoracic Society to work together to create an implementation guide to help reduce those barriers and further encourage implementation of screening at community facilities and healthcare systems across the country. Starting a successful and effective clinical lung cancer screening program can be a complex endeavor and requires careful coordination of many clinical and administrative activities. A panel of experts weighed in on establishing a lung cancer screening program, including best practices for screening programs, clinical practice guidelines, and policy statements to ensure that benefits of the screening outweigh the harms as screening advances from the clinical trial setting to an implementation in a real-world practice. Strategies for implementation, program structures, and panel profiles are also included in the guide. The aim of the document and the website is to provide a pragmatic guide and toolkit of how to design, implement, and conduct a lung cancer screening program based on a survey of experts in lung cancer screening centers representing a diversity of institutions and knowledge bases throughout the United States. The next slides will describe some of the important aspects of the guide, and if time allows and technology works, I'll give you a brief real-time demonstration of the website. Members from the Lung Association and the American Thoracic Society, known for their involvement in lung cancer screening activities, were selected to participate in this project. A panel of experts in the areas of research, behavioral sciences, qualitative improvement, nurse navigation, patient advocacy, and clinicians involved in leading and performing lung cancer screening in the fields of pulmonary, radiology, interventional pulmonary, primary care, oncology, and thoracic surgery were all assembled. The panel developed a document using information gathered from clinical practice surveys that aim to address how participating members approached common problems encountered in their own clinical lung cancer screening programs and how they were implemented. The answers to the questions in the guide provide practical guidance to commonly encountered implementation issues. On this slide are answered by the panel. Participating panelists from centers around the country are outlined in the panel profiles and the organizational structure on the website. This allows the reader to understand the environment that the panelist is working from and how their program may differ from those at another institution. So the guide is literally a how-to or on implementing a screening program at your institution based on your resources. We launched a user-friendly version of the Lung Cancer Awareness Guide in November of 2018. And as I mentioned, to access the guide, it's lungcancerscreeningguide.org. The American Lung Association and the American Thoracic Society will periodically update the guide as new tools and information become available. These are the main sections of the guide, and I will discuss some of them in a little more detail in the upcoming slides. The section entitled Lung Cancer Screening Program reviews the foundation necessary for setting up a lung cancer screening program. This includes the population recommended for screening, program structure which can vary based on resources, governance, insurance reimbursement, and community outreach. The radiology requirements section discusses standardizing the screening process, talks about the structured reporting requirements, and the establishing of quality metrics and benchmarks, as well as surveillance and follow-up of patients. Included are protocols and benchmarking examples, especially how to assess the detection and false positive rates and how to track patients through the process. Clinicians play a key role in determining the eligibility of patients for lung cancer screening, ensuring patients understand the benefits and harms of lung cancer screening and working with patients to make decisions about screening that are consistent with the patient's values. This section shares the process of shared decision-making, which is encountered and is required for Medicare reimbursement, as well as suggested messages, resources, and smoking cessation interventions in this section. This section for referring physicians is available for physicians seeking how to refer patients to their program. This includes information for the physicians on smoking cessation counseling that is offered and examples of outreach and education for the referring providers from that center. When a lung cancer screening center is developed, systems must be established to help patients and physicians navigate the program, including proper identification, notification, and follow-up of patients and their health and reporting to their healthcare providers. This section includes reminder letters, smoking cessation support, and American College of Radiology registration reporting, which is another Medicare requirement for reimbursement. The resources section contains an easy-to-navigate directory of materials, tables, figures, articles, industry information, and other items that can help your institution implement a lung cancer screening program. These include decision aids, promotional brochures for patient outreach, smoking cessation resources, and other tools that can help support lung cancer screening implementation at your particular institution. The About Guide tab near the right corner of the section directory includes some important step-by-step guidance about how to best access the full breadth of the information on this website. Determining who to screen may be one of the first decisions you make after deciding to start a lung cancer screening program. Do you offer it only to those who meet the Medicare and USPSTF eligibility limits that provide reimbursement, or do you include other at-risk populations with criteria fitting, for example, the National Comprehensive Cancer Network Category 2? How does your program consider those recommendations to screen individuals outside of the traditional eligibility requirements, and how will they be handled financially? As mentioned earlier, shared decision-making and registry reporting are required by CMS. This report includes answers from physicians about good ways to go about making sure that the patients are informed of the risks and benefits through the shared decision-making process and where that encounter should take place. These questions and more need to be answered up front when setting up your program and are addressed in our survey by the lung cancer experts that are included. Lung cancer screening programs generate activity across multiple departments throughout the organization. Accounting for these diverse sources of downstream revenue can be challenging, but it's important when seeking to secure resources from the administrative C-suite executives for your program implementation. This and additional considerations for engaging senior leadership beyond the proven mortality benefit to the high-risk population are addressed by questions and responses in the Lung Cancer Screening Implementation Guide from the different experts. Development of a multidisciplinary steering committee can serve as a powerful coalition to guide program development, provide a forum to establish consensus, and promote a team-based approach to overcome obstacles to program implementation. This type of collaboration has also been shown to improve the diagnostic and therapeutic paths taken for patients found to have abnormalities on their scans. Under each of these topics are answers from the various institutions participating in the development of this guide. The effectiveness of a lung cancer screening program is dependent upon multiple factors, including access to the scanning, monitoring of smoking status and cessation monitoring, cancer detection rates, and procedures performed with both results and complications. Similar to mammography, regular assessment that quality metrics and objectives set forth by the steering committee are met and deficiencies are addressed in a timely fashion is necessary for a successful program. Examples of approaches to these issues from various institutions are also found in our guide. You can find information from what data are collected, to whom are the data reported, and to how the metrics can be shared and reviewed. The Lung Cancer Screening Implementation Guide also has a section that outlines the strategies for implementation. Some of the important strategies include making sure you have core personnel involved in the lung cancer screening program. And this includes a myriad of people, including primary care, CT schedulers, program navigators, CT technologists, radiologists, pulmonologists, thoracic surgeons, oncologists, smoking cessation counselors. There's also a section on how to get radiology on board when setting up these programs. Getting a handle on and understanding how many patients you may see screened at your institution is also an important factor in deciding to proceed. An example from one of the institutions used their mammography data. There are approximately 60 million women qualified for mammography each year, and 8 million patients qualify for CT lung screening. Therefore, a rough estimate could be for every 7 or 8 mammograms your institution performs, you might expect to perform one low-dose CT lung cancer screen. The structure of each screening program will depend on available resources, the type of institution, the practice, and the skills and interests of the individual providers. Often lung cancer screening programs will build upon or arise from pre-existing multidisciplinary lung cancer clinics or tumor boards. Most lung cancer screening programs fit within one of 3 general categories. At one end is a centralized lung cancer screening program that actively recruits eligible patients, conducts education and shared decision-making visits, assists in smoking cessation, and schedules, orders, and performs and interprets all screening studies. The program also then arranges consultations, follow-up studies, and tracks all the clinical data and outcome. The centralized program communicates results and plans for future treatment to the patient and the referring provider. This model requires a significant amount of resources, including a dedicated lung cancer screening coordinator, clinical leadership, and an integrated multidisciplinary program team. At the other end is a decentralized program, which performs the screening exam and gives the interpretation, but leaves the referring provider responsible for all other aspects of referring to a specialist or notifying the patient and tracking follow-up of the studies. In between, on a fairly complicated slide, you see there's a whole host of variations between a hybrid of central and decentralized. And again, this will be based on what your institution can do and the physicians interested in the program at your institution. This is another place where questions and answers from the different institutions can be helpful. How do you reach out to eligible patients? How does your program identify patients who may be eligible? Strategies should be developed to identify these people who meet the program's screening criteria. The most important strategy is education of the community of providers who will refer patients for screening. Primary care champions in the area for the program can provide guidance about how the most effective means of communication with the primary care groups in your area. Similar education and marketing efforts targeting potentially eligible patient populations should also be considered. Patient education tools in the form of pamphlets, call lines, internet resources, and letters can be considered in conjunction with the marketing experts, and these are included in the guide as well. The Lung Cancer Screening Implementation Guide allows you to learn ways you can establish systems to offer screening to the right people at the right time. An important Q&A is included, which each answers questions such as this: how do you reach out to eligible patients? How does your program identify patients? And who may be eligible? Programs should also develop and implement a follow-up notification program that includes the patients and the providers. This can be accomplished with a database in radiology that includes a date of follow-up and automatic letters for missed follow-up appointments. Notification should also be sent to the ordering provider. System-wide tracking mechanism for previously identified nodules in need of follow-up is a safety net for ensuring follow-up. If follow-up is overdue, then an outreach call to the provider can be performed and follow-up tracked from there as well. Certified letters to patients should be provided from the provider's office or from the nodule team if a follow-up is not completed. There are a number of automated pulmonary nodule and lung cancer screening software systems that can make this a very efficient process, but the cost and the integration with existing hospital computerware can be a challenge. Some of the institutions in this guide use these resources, and you can get some information from them. You also have to decide who's responsible for managing abnormal findings on your lung cancer screening scan. Program navigators track and manage follow-up for lung RADS categories 1 through 3. Any lung RADS 4 or higher are recommended to have formal pulmonary consultation with the multidisciplinary team as a backup. There are also incidental findings, or what's called S-positive findings, that are managed by the ordering clinician and tracked through the program navigation. As you can see here, the guide includes a sample follow-up screening letter as well. Another important question is how data is submitted to a registry. You can check responses from the different institutions under each tab and get a sense of the workflow involved and how duties of the lung cancer screening team may be most efficient. As mentioned earlier, this is an important component for Medicare reimbursement. Required reporting elements are listed on this slide. This may seem daunting, but the more organized the input is from the start, the more likely you will have the data that you ultimately need when looking at metrics of performance and looking for ways of improving. I said earlier, if we have time, I'll try to pull up the website and show you a live demonstration of some of the sections. However, I would like now to walk you through our third annual State of Lung Cancer report that was released earlier by the American Lung Association, earlier this week. The State of Lung Cancer report provides state data not previously available in other reports, with important new results on lung cancer disparities among racial and ethnic groups. We believe this report will provide policymakers, researchers, healthcare practitioners, and anyone committed to ending lung cancer a foundation for identifying where their state can best focus its resources to decrease the burden of lung cancer. Through this report, we believe we can empower the public with information that can leverage or start the local change we need to see. And since knowledge is power, these data can be used to galvanize policy change. We know some of the basic facts very well. Every 2 minutes and 18 seconds, someone in the United States will be diagnosed with lung cancer this year, accounting for about 1 in 4 cancer deaths. The 5-year survival rate is now 22.6%, as reported in our State of the Lung Cancer report this year. And this represents a dramatic 13% improvement over the past 5 years. In order to better describe the lung cancer burden for each state, we've compiled data from various sources that delineate the toll of lung cancer in each state's population. The nationwide burden of lung cancer is large, but it's not the same everywhere. This report finds that there's more that each state can do to turn the tide against this terrible disease and save more lives. I'd like to note that some of these data are not available for all states. As it is important to fully understand the lung cancer burden, we would hope that this report helps some states see where their data gaps may be, so as to encourage all states to ensure that they collect data that's important for us to evaluate. The measures we have compiled and ranked where possible include several categories: new cases, survival, early diagnosis, surgical treatment, lack of treatment, screening rate, and the coverage of screening by state Medicaid fee-for-service programs. The first new item we added this year was a 5-year trend for the different metrics I mentioned earlier: the cases, survival, diagnosis, surgical treatment, and lack of treatment. These trends will tell whether or not a state is increasing, decreasing, or remaining flat over the last 5 years. The other area we added this year was disparities among racial and ethnic groups for the same parameters that were mentioned. To help support this new disparity information, we've added a number of resources that are available on the State of Lung Cancer website at the American Lung Association's website. In addition to the text describing rates by groups, each state page also has a chart similar to this one, visually reporting the disparities between the different groups. There's also state infographics that have a new box this year which features highlighted disparities for each state. Generally, this was whatever group or metric had the greatest difference compared to the white population in that particular state. There's also an entirely new one-pager this year that covers national rates for each metric and group compared to the white population. There's also a spreadsheet that includes every available rate by group and metric for each state. It shows how a group compares to whites in that state, but only if the difference is statistically significant. I know spreadsheets can be intimidating, and this is a big one, but don't be overwhelmed. This can be a really helpful resource, and I would recommend using the filter feature on the website to focus in on any particular issues and states you want to look at. Moving on to the rest of the report, the rankings chart show how the rate of each state data was available. The dark gray bar in the middle is the national average rate. Whichever state you've selected will be highlighted with a red bar. You can see other states simply by scrolling over those bars. The background colors show the 5 tiers we've grouped states into: top and bottom, above and below average, and average, to help visualize where your state rates. The report begins with the rate of new cases on the incidence rate for each state and the District of Columbia. Incidence is defined as the number of new cases per year and is calculated per 100,000 population. The next area of the report addresses survival. This chart shows state rankings by the percent of people who are still alive 5 years after being diagnosed. We're excited to share that the national rates from this year's report is 22.6%, and as I mentioned earlier, this is a significant 13% improvement over the past 5 years. Connecticut had the highest survival rate at 27%, while Alabama was at the lowest at 17%. We believe this can be an important measure to be made available at the state level so that each state can better understand how their lung cancer patients are faring and better evaluate patient care and treatment. Nationally, only about 23% of cases are diagnosed at an early stage, when the 5-year survival rate is much higher at about 59%, and the disease is more likely to be curable. Unfortunately, about 47% of cases are not caught until a late stage, when the survival rate drops to about 6%. The early diagnosis rate has increased 33% over the past 5 years. It was actually highest for Massachusetts at 28% and lowest for Hawaii at 18%. Nationally, early diagnosis rates were highest for whites and 13 to 16% lower for individuals of color. Lung cancer can often be treated with surgery as part of the first course of treatment if it's at an early stage. While surgery may not be an option for every patient, those who receive it as part of their initial treatment have higher survival rates than those who do not. Nationally, about 20.6% of cases underwent surgery as part of their first course of treatment. This was a 1% increase over the last 5 years and ranged between 30.7% high in Massachusetts to a low of 13% in New Mexico. Patients who are not healthy enough to undergo the procedure or whose cancer has spread too far may not be candidates for surgery, obviously. Other treatments may need to be recommended instead, which include chemotherapy, radiation, targeted, or immunotherapy. On this slide, you see the national surgical treatment rates were highest for Asian Americans and Pacific Islanders, and lowest for Black Americans, and indigenous peoples, which includes American Indians and Alaskan Natives. Some lung cancer patients will not receive any form of treatment for legitimate medical or personal reasons. But the wide gap and lack of treatment rates between states suggests there may be additional factors contributing, like stigma, fatalism, and access issues. The percent of patients who receive no form of treatment is 15.2% nationally, which is a 9% improvement over the last 5 years, but there's a range of a low of 7.5% in North Dakota to a high of 29.5% in Arizona. Nationally, lack of treatment rates were lowest for white Americans and highest for Latinos, ranging from 7 to 39% worse for people of color compared to white Americans. As we discussed earlier in the talk, screening for lung cancer with annual low-dose CT scans among those at higher risk can reduce the lung cancer death rate by up to 20%. If all of those Americans at high risk for lung cancer were to be screened, about 48,000 lives could be saved. Unfortunately, nationally, only about 5% of those at high risk were screened during 2019. Massachusetts had the highest screening rate at 18.5%, while Nevada had the lowest at 1%. Fee-for-service state Medicaid programs are one of the only healthcare payers not required to cover lung cancer screening. The American Lung Association analyzed lung cancer screening coverage policies in state Medicaid fee-for-service programs to assess the current state of lung cancer screening coverage for that Medicaid population, and found that 38 Medicaid fee-for-service programs covered lung cancer screening, 9 programs did not provide coverage, and 3 states did not have information available for us to use. This chart demonstrates where Medicaid fee-for-service programs cover screening, those that do not, as well as those states where service is not available. As you know, tobacco use is the leading risk factor for lung cancer and accounts for 80 to 90% of cases. While we have seen historic decreases in the national smoking rate, not all Americans or regions of the country have benefited equally. This chart demonstrates the percentage of adults by state who are current smokers. Utah had the lowest adult smoking rate at 9%, while West Virginia had the highest at 25.3%. So thank you for your attention, and thank you for all you do for your communities. I hope you have a sense of how the American Lung Association is striving to meet one of the strategic imperatives of our mission, and that is to defeat lung cancer. You can certainly review much of this information I've gone over at the American Lung Association's website, as well as the Lung Cancer Implementation Guide and the State of Lung Cancer Report, all of which are linked together. So if I can go to a screen share before we get to any questions and answers, I want to just go over how the guide can work. Let's see if we can do the technology here. Hopefully you're all seeing my screen at this point. And we are live on the website. And as you can see the different sections that I talked about, you hover over them, click on it, and it sends you to that area, which also breaks down into a number of different areas specific to the radiology. Establishing the program, scheduling the screening, benchmarking. So we can go into each one. And this is where you get the question and answer format. So that if you want to know how orders or schedules are for lung cancer exams are put together, you click on this and you get responses from different institutions as to how they do it. And by going back up to the resource page and looking at where these institutions are, you can see whether or not this is an academic center, community center, small community hospital, and start to see how they may handle it the same way that your particular institution would be interested in handling it. We'll also go to the resource section, which has a lot of promotional information you can use for your programs, has smoking cessation resources, a lot of patient-focused materials, as well as information about insurance coverage. And then there's the all-important shared decision-making, which can include resources around shared decision-making and risk implementation devices. There's also quality metrics and EMR documentation for how to do the shared decision-making and how to submit information to the Lung Cancer Registry, which, as I said before, is a Medicare requirement for reimbursement. So again, this is set up in this manner so you don't have to read from the beginning to the end. And the hope is that if you have a particular question surrounding either the current screening program that you have or how to set up a program, you can go in and find a department that has the answers for you and seek out who the individuals are. You find the resources of the individuals. This shows you the individuals who are part of the ALA and ATS panel, where they're located, what institutions they work at. And again, it gives you a sense as to the type of facility that's being surveyed for part of this program. So I guess at this point, I'll open it up for questions and go from there.
Thank you so much, Dr. Rizzo. This has been incredibly informative. And I think, Ryan, you can unshare the screen and take us back to the slides. That'd be great. Thanks. I actually had a couple of questions as you were talking that I thought I'd get us started with. One is, as you are hearing organizations put this together and, you know, the various inputs from your committee, how are organizations collaborating to offer this service? I know depending on where you are, there may be lots of different organizations who could work together to provide this to the community.
Well, I mean, that's exactly it. There's a lot of different variation in what can be done at a particular institution, depending on the geographic area, rural versus urban, and also then the working relationship between other hospitals as well as private radiology departments, specialists in the community. So it really does require mostly getting a champion at each institution who recognizes the importance of setting up a program like this and then works with the different departments as well as different hospitals to try to make this happen. The whole thing about coordination is so important. What we're seeing, unfortunately, as we increase the number of people who get screened that first time, there's a significant drop-off in people not coming back for that second or third screen, either for various reasons, and most of it has to do with logistics. And we know, however, that when patients fail to come back for that screening program, that's when you miss the chance of catching the cancer early. They come back 3, 4, 5 years later now with a cancer that is no longer stage 1. You've lost that opportunity to potentially save their lives. So collaboration is very important. The other thing that some institutions are doing, particularly, I won't say just rural, but urban centers that have a fairly large rural area around them, there has been the development of some of these mobile screenings that I mentioned on the slide. This is particularly popular in the North Carolina and Kentucky area, in Tennessee, Dr. Hedrick out of Tennessee, and then the Atrium Healthcare Center in North Carolina. They have 2 or 3 days a week where they send a van out into the surrounding counties and do the screening. And the important thing there is to try to utilize the local facilities, the local physicians out in these rural areas, but also have the opportunity to send patients who need further care that is not available in their particular site back to the tertiary care center at the home facility. So that's another way to kind of open up and decrease barriers to getting this screening performed.
Great, and I think that may get to my next question a little bit, which is, I know certainly with historically underrepresented communities, there has been a lack of trust of the healthcare system that has contributed to many of the disparities that you mentioned that are now, highlighted in the report. How are you seeing organizations really meet people where they are and work with the community to address some of those issues of mistrust and challenges?
Sure. Yeah, I think you used a great term, meet people where they are. I mean, the message has been that you just can't put together educational material. You can't have a volunteer or a staff member from the ALA go out and recommend this being done because it's the right thing to do. You really have to get to the grassroots level of community messengers, community ambassadors that are recognized by the community, may look exactly like the community, and have the same cultural beliefs, as well as some of the same misperceptions and mistrusts that have been present for a lot of years in communities like that. And examples, particularly among the black population, go back to the Tuskegee experiments of syphilis back in the mid-1900s. So there's definitely mistrust and misperception of what should be done. And we're seeing that play out with the COVID-19 pandemic. Multiple surveys between last spring and now, when people are asked about their willingness to get vaccinated for COVID-19, averages between 35 to 50% say they're not in a hurry to get vaccinated for some of the various reasons we mentioned. They think it's being developed too fast, they don't trust the safety, and they also don't trust the government. So these are things that have to be dispelled, but they have to be dispelled by a trusted person in that community, and that's what ALA, which has always been a grassroots organization, we have to continue to get people in the communities. We're working right now with the Coalition of Black Churches to try to set up a working relationship there. There's over 30,000 of those across the country that we think would be a very important way to let information permeate throughout the community in a trusted fashion around lung cancer screening, but also around COVID-19 as well.
Absolutely, absolutely. And then I'd be curious just to know from your own experience, some of the things that you maybe wish you had known going into this work, and things that you wish you could go back and tell yourself, should you have a time machine, to say, oh, we should have done this.
Well, there's probably a lot of things that you learn when you try to put things together like this. I can't point out one particular issue. I think it does go back to trying to get collaboration between people who are going to be the champions, and that includes the clinicians, but also includes an administrator, somebody in the C-suite who understands the economics of it. Part of the hospitals that we have in this survey actually realized that they were safety net. They had large safety net hospitals around them, and they just felt it was a community service to make this available to the population, whether it was covered or not. They felt it was saving lives, and that takes a very important C-suite and organization to make that commitment, but it's happening across the country in different areas. So it's a collaboration among the champions, and I mentioned all the list of specialists, because multidisciplinary approach to this has to be the best way for patients to get the care they need. They need the surgeons, the pulmonologists, the radiologists, and also the oncologists working together to figure out what's the best option for this patient's cancer once it's discovered. If it can be removed and surgically cured, great. If not, what are some of the second, third modes of treatment that are available? So collaboration is probably key, and if you try to do this without collaborating, that's probably the main thing I would say, is go back and make sure you have all the people you need involved and willing to spend the time and champion their particular department.
Wonderful. Well, thank you so much, Dr. Rizzo, for sharing your insights with our group and all of the great work that the ALA has put together to make this possible. We really appreciate your time. A copy of this webinar will be available on the AHA's website, so folks can go back and refer to it. And we look forward to seeing you all on our next webinar early next year. Thanks so much.
Thank you for the opportunity. Bye-bye.
Bye.
Thank you, ladies and gentlemen. This concludes today's conference. All participants may now disconnect.